What? Yeah. Hey, Risa.
Hi, how's the lighting?
Good. You look good.
Okay, and then does this look like I'm looking at the camera? I don't know, I have to like look at my keys. Does that look like it?
Yeah, it's pretty close. I mean, like if you tell me that you're reading your slides, then I would pay attention to that, but otherwise I would not notice.
Well, because I realize it's hard to like look at my slides and the camera.
I know. It's like you got to be, I don't know, multitasking. Yeah. I've got 2 computers going right now.
Okay, so it doesn't look like that bad right now.
No, it looks good.
Okay. Sweet. I'm gonna get some water.
And there's people, I'll wait on the waiting room until like we're closer, just in case you want to pull up your slides or anything.
Oh yeah, I guess I should try doing that. Let's see. Should I screen share first and then present? Probably, I think that's the way to do it.
Yeah, I think so.
Where is screen share? Oh boy. And then I click screen, this one, share. Is that working?
I see presenter mode.
Okay. Is that working?
That's perfect.
Okay. Then I need to move this baby. Okay, does that look like I'm looking at the camera? Kind of. No. Now?
Yeah, you look like you're looking at the camera.
Okay. What about, it's annoying because my Zoom screen, if I want to see what myself looks like, I have to look to the left because the Zoom.
Oh yeah, and then you're only halfway in the picture now. You might have to move the camera.
And now it's 2 down. I need like a booster seat. How's that?
That looks good.
Ideal. Which way should it go? Is that better?
That looks good. That's perfect.
I see how you can only see my head. Hey.
Wow, ring light. Oh, come on.
Get on my level, Bryce.
That's so sick. Did you join it?
Yeah.
Okay, what are you doing are you doing presenter mode? Oh, you got 2 screens. You're
Yeah.
smart.
You
I'm
can do
sharing part
Susan's
of my
office
screen.
if you do 2 screens.
Yeah, tell Bryce to go to my office. He can do that.
If you want 2 screens.
I can share part of my screen, which I've been doing.
What does that mean?
Like you can only share
that
one part.
Oh, that's cool.
But it's a little bit like that's so sick. The quality isn't quite as good. Yeah.
Well, this light is out, which is like, this is key. Yeah.
Okay.
But now I look too bright.
You look good.
As a backup. Are you guys on the Zoom meeting right now?
Yeah, and you can, if you want to email me.
Tell him I just let him in.
We just let you in. If you want to email me your slides,
you can pull it up.
I could pull it up here.
Just as a triple back.
Right.
Susan, can you hear me?
I can.
Cool. Let me see if we can get this thing going. How I want it to work.
Your video's not on, but you probably know that.
All right, perfect.
There we go.
Video looks okay, not as good as Reese's.
Well, I mean, you're just not going to look as good as Reese. I mean, there's that.
That's true. That's also, yeah. There's nothing I
looks
can do
good.
about that though. You cannot start sharing screen while other participant is sharing.
Oh, she's got to stop sharing. I'm going to make her stop.
Okay, make her stop.
Stop participant. Okay.
Oh, wow. Share screen. All right. Can you
Looks
see?
perfect.
It does
looks
look
like
perfect.
presenter. I mean, it looks perfect. It looks good.
Awesome. So you can only see that stuff, and then I can
See none
do
of
that.
your notes.
Cool. So it works.
Yes.
Does it look crappy quality or it's okay?
No, looks good.
Sweet.
I mean, if you told me it looked more granular than Reese's, I would go, oh yeah, okay, now I see, but I wouldn't notice otherwise.
Sure. All right. That's all I need to hear.
All right, good. Bryce, who's first?
Wait, who's first?
Yeah, I'm asking.
Oh, I think Reese is first.
Okay. Reese, I'm gonna stop your video for the moment.
Stop my video?
Yeah, for the moment. I just turned your camera off right now, so nobody will see you come sliding back in.
Okay, I should probably mute mine then too, huh?
I can do that.
All right, good morning, everyone. I hope everyone is doing well this morning. We are looking forward to grand rounds this morning from we have a couple of resident presentations. We do not have any meetings or journal clubs or anything to follow today. And just as a reminder, we are scheduled to also do grand rounds next week virtually. Over the next week to 10 days, we'll be sort of assessing safety issues and health issues, and I'd like to get back to our at least our hybrid model back at Mercy in February, but we'll send out an official announcement about that. Our CME color for this morning will be white in honor of what seems to be snow week. I know we have another potential storm coming here at the end of the week. Hopefully it won't impact our daily care very much. I know I'm on trauma call Saturday and I've got a 4-wheel drive car, so we should be good, at least with one person showing up. But without further ado, I'd like to invite Dr. Reid to go ahead and share her screen, and we will look forward to hearing about the orthopedic stethoscope.
All right, thanks, Dr. Pat. So I'm Reid, I'm one of the current chiefs, and today I will be talking about the use of ultrasound in orthopedics. I do not have any financial disclosures. So before we start, I'd like to think about a couple cases. So our first one is a 36-year-old former athlete who's playing some pickup basketball, tried to block a shot and heard a pop, and then had immediate pain to his ankle. The second case is a 6-year-old patient who recently moved to Charlotte, was doing some heavy lifting with boxes and started having shoulder pain afterwards. And he does have a history of a pacemaker. And our last one was a 16-year-old baseball player who started having medial elbow pain after a game of pitching. So there's a growing interest of ultrasound technologies over time. And this is represented by the amount of publications that have been done specifically with regards to ultrasound education over the past several years. So as with everything, if we look back far enough, we can trace it back to the Greeks, starting with Pythagoras and later Boethius, who both were studying sound waves, Boethius by dropping pebbles of water into a calm stream. But it wasn't really until the 18th century when physicists started analyzing basically how bats were able to navigate and fly through the dark, deducing that they actually employed sound rather than light to orient themselves. So this formed the basis of ultrasound physics, which didn't really take off until 1877, when the theory of piezoelectricity was discovered, which is basically the ability of a crystal to produce an electricity in the form of vibrations produced by the ultrasound wave. However, ultrasound really didn't take off until 1915, specifically after the sinking of the Titanic, when scientific efforts were rallied to develop a system to basically be able to visualize underwater structures. Later on in World War I, the French government actually commissioned research to kind of use these high frequency sound waves to find German submarines. And then that, with the basing of this data, we developed the US Navy system was actually able to develop sonar technology. It really wasn't until 1942, however, when ultrasound was first used for medical diagnoses. And over the late 40s and 50s, we start to see ultrasound being used in medicine, the first echocardiogram, the introduction of ultrasound into OB-GYN. Throughout the 60s, 70s, and 80s, we start to see the evolution of sonography, the technologies becoming more sophisticated, improving the quality with 3D imaging capability. And we start to see how it became kind of from a field of a couple pioneers to basically an entire profession, with these devices becoming smaller, more portable, and more user-friendly. So all forms of ultrasound basically revolve around generating acoustic energy. So this piezoelectric effect, having the crystal within the transducer producing an acoustic pressure wave, that's then transmitted through the tissue via molecular collisions and vibrations. Then the beam is either reflected or refracted by the transducer received, and then converted into electric current that's then displayed in an image. So the most kind of unsophisticated ultrasounds were the transmission method, where the receiver was actually positioned on the opposite side of the specimen. Then we see the pulse reflection method, where the receiver and the transmitter are on the same side. There are basically three different categories: A mode or amplitude, which is our most basic 1D image that has the greater the signal returned by the transducer, the higher the spike or the amplitude. B mode, which is brightness. That's the most commonly used mode today. It's a 2D characterization of tissue that relates the brightness of an image to the amplitude of an ultrasound wave. And finally, we have M mode or motion mode, which basically relates the amplitude of an ultrasound wave to a moving structure. So the first report of musculoskeletal ultrasonography was actually published in 1958, where ultrasound was used to measure the acoustic attenuations of articular and periarticular tissues. These initial developments were led in the field by radiologists. However, ultrasound over time gradually became adopted by other fields as the technology improved, but its practical application in MSK disease didn't really become more widespread until the diagnosis of congenital hip dislocation on ultrasound. So in this paper in 1980, outlines the practical results of ultrasound making the diagnosis of hip dislocations over an 18-month period, emphasizing particularly how this method is going to be harmless to the patient, economical, and simple to perform. In this paper, he describes taking on average 4 minutes to image both hips. But I think my favorite part of this study was actually how they documented their findings by taking kind of a Polaroid picture of the image and putting it up. So while we've gone a long way from this picture on the left, this well-known view on the right that can appear on our orthopedic boards, I think ultrasound diagnosis in infant hips has greatly improved our ability to screen without the inherent risk of radiation. And that's probably one of the biggest draws to using ultrasound, particularly in the pediatric population, is reducing ionizing radiation. So on average, a person in the US receives a dose of 3 millisieverts per year. And this is just a table of completion for average radiation doses for common imaging studies, with CT being the most, X-ray being the least. And when we look at these images, it's important to understand the echogeneity of different musculoskeletal structures. So tendons and the surface of bone are going to appear hyperechoic or have a bright echo. Muscle is going to be hypoechoic or have a dim echo. Simple fluid is going to be anechoic or no echo. And then certain structures, such as peripheral nerves, are going to have a mixed hypoechoic picture. So when we look specifically at ultrasound in the pediatric world, this review article from our own institution highlights its clinical applications. So as previously discussed, one of the most common uses is in the screening diagnosis for hip dysplasia. You can also use it to monitor the treatment of dysplasia, but there are reports of using ultrasound to diagnose SCFE, as well as looking at FAI, although it is not great for evaluating the labrum or deep articular structures. You can use it for a dynamic evaluation of psoas tendon with snapping hip pathology, help guide your injections, for the assessment, monitoring correction, and even evaluating recurrent deformities in patients with clubfoot, looking at different forms of sacral dysraphism and tethered cord, looking at the management of peripheral nerve injuries for neonatal brachial plexus, helping to guide our Botox injections, looking at foreign bodies, such as the picture below. This was an X-ray negative patient who actually had a splinter in their hand, and also diagnosing hemangiomas, which is the most common soft tissue tumor in kids. So as we can see, ultrasound can be particularly useful in evaluating soft tissues. And one of the most studied areas is actually looking at the tendons of the shoulder. So this study compared ultrasound with MRI, and it's been shown to have equal accuracy for detecting both full and partial thickness rotator cuff tears. And this has been proven in multiple studies in the literature, with ultrasound having equal sensitivity, specificity, and predictive values. And beginning orthopedic surgeons, which they defined as less than 1 year of experience, were able to identify rotator cuff tears with high accuracy as well. They didn't see any difference in sensitivity or specificity when comparing ultrasound performed by orthopedic surgeons versus radiologists. And another study indicates that patients with shoulder pain actually preferred ultrasound to MRI, with the main reasons being MRI too long and higher patient satisfaction with regards to pain. There's also even a high accuracy in the postoperative period after patients have gone a rotator cuff repair, looking at tendon healing versus re-tears with ultrasound. And it's also useful for evaluating ankles and tendons and ligaments in the ankle. So this used ultrasound to look at the interosseous ligament for high ankle sprains, looking at syndesmotic injuries with ankle fractures having a high sensitivity and specificity. You can look at impingement of the posterior tibial tendon, as well as fraying or subluxing peroneal tendons. This one study showed that ultrasound was actually more sensitive and accurate than MRI in detecting ankle tears. So this is just a picture. First, on the left, we have a transverse view demonstrating how you could see this normal hyperechoic structure, but a break in the middle. And then kind of just putting the probe on the opposite ankle, you can see the continuous hyperechoic structure indicating an intact ligament. So for looking at tendons in the hand, ultrasound can be especially helpful, especially when the exam is limited by pain. It can detect flexor tendon lacerations, as well as localizing the proximal stump, which in some cases can reduce your need for intraoperative exploration. It also is useful for evaluating postoperative tendon rupture, kind of differentiating that from adhesive scarring. So this is a patient who came in with loss of motion, and the question was whether or not there's scarring or repeat rupture. This ultrasound image probe was placed in clinic. You can kind of see a gap in the tendon here. So it can be particularly useful for answering a simple question in your office without having to go back to the OR. So for a dynamic exam, it also is a unique feature of ultrasound, being able to evaluate kind of chronic soft tissue ankle injuries. This study found that ultrasound was specific for diagnosing correctly 14 of 17 ATFL tears. Looking at the thumb, specifically a dynamic exam for looking at UCL injuries and accurately identifying operative sternal lesions. An additional feature of ultrasound is you can use the water bath technique, which can reduce the discomfort and allow a dynamic exam by just placing the patient's extremity underneath lukewarm water with a transducer on top as pictured there. So other things we can see with ultrasound, it's also useful for compressive neuropathies. It's actually been shown to have a sensitivity comparable to that of nerve conduction studies. It's going to be cheap and more comfortable for the patient. Usually median nerve enlargement with a cross-sectional area of 10 millimeters squared is the most common parameter used to diagnose carpal tunnel syndrome on ultrasound. It's been also identified as useful in diagnosing cubital tunnel syndrome with, again, a similar cutoff, but with the use of ultrasound, you can also do a dynamic evaluation to look for ulnar nerve subluxation. So these top pictures, this is the normal anatomy of the carpal tunnel with the transverse carpal ligament up top. Here you can see an enlarged median nerve in these two pictures below. So Cochrane review showed that ultrasound with nerve blocks has a superior motor and sensory blockade. It's also been able to detect occult dorsal ganglion cysts with a high sensitivity equal to MRI. It's been used to assess neuroma locations, differentiating symptomatic neuromas from other symptoms of phantom limb pain, and also has been successfully able to diagnose radial nerve transections in the setting of closed humeral shaft fractures. So we think about ultrasound and evaluating things that we normally can't see on X-ray, but here's something where ultrasound has been useful in evaluating bony injuries. It's particularly looking at callus progression. So normally on X-ray, it takes about 6 to 8 weeks for callus to be present and beyond. But here you can use 2D ultrasound to evaluate soft tissue bridging callus, particularly in the early fracture healing stages. And this can be particularly helpful in the presence of metallic hardware, as you can adjust the probe to visualize areas free of interference. So this picture on the left shows kind of the normal cortical bone. Here you can see the hump bridging callus crossing the fracture site. This picture on the right shows, cortical, basically normal cortical bone. Here you can see the gap at the fracture site. This is just the corresponding X-ray. So in terms of whether or not this helps, this study basically used ultrasound to see if it can predict delayed union. They had 14 tibia fractures that were managed with intramedullary nail, and they prospectively scanned them every 2 weeks until union was noted. They found that the most reliable predictor of union was going to be progressive loss of visualization of your nail at the fracture site. They were able to see bridging callus on ultrasound at an average 6.5 weeks versus 19 weeks for X-ray. And this other study looking at ultrasound for helping to diagnose unclear soft tissue injuries in the upper extremity, they basically had 195 patients with an unclear diagnosis that ultimately had ultrasound. 43% of these end up having surgery. And they found that there was actually a better agreement between the ultrasound and operative diagnosis than between the clinical and operative diagnosis. And in those cases, ultrasound was able to change the management from some patients to non-operative treatment, adapting the surgical approach, as well as choosing the choice of anesthesia. So what else can we learn from ultrasound? It's been used to identify wound and fluid collections that may be associated with surgical site infections. We know there's a growing, soft tissue and skin, soft tissues infections and skin infections have doubled over the past 10 years. Ultrasound has a greater sensitivity and specificity compared to your clinical exam. It's been shown to be similar to a CT scan. So using it to visualize fluid collections around a plate, differentiating that from bursa. And this may perhaps lead to an earlier detection of infection or reduce the need for unnecessary INDs. So this is just an ultrasound picture of an abscess cavity compared to cellulitis with the classic cobblestoning appearance that you'll see, which is basically just fluid surrounding the echogenic structures in the subcutaneous tissue. So when you talk about implicating this and implementing this in your practice, some of the biggest reservations from a survey of orthopedic surgeons showed there was a concern for false positive and false negative results, a lack of experience, as well as insufficient training. But when you ask yourself, can you apply it in your practice? I'm here to tell you that yes, you can. We know that Rome wasn't built in a day, and similar to arthroscopy, with time and practice, you can get facile at ultrasound. And there's actually research here to prove it. So this study looked at 15 orthopedic residents and their ability to measure ankle or tendons after multimedial tutorial. They found that their accuracy and comfort level improved, and the majority of residents actually plan to use them in their practice afterwards. This next study similarly involved an ultrasound course, which is basically 2 hours of online videos, followed by a 4-hour-long half-day course. They evaluated residents with a written pre-course, a same-day post-course, 6-month follow-up, as well as scoring on a practical shoulder exam. And they found that their written scores were maintained. At the 6-month follow-up, there was a decrease in their practical exam scores, but the comfort levels with all ultrasound technology had improved at 6 months. And this just doesn't apply to residents. This study looked at hand surgery fellows after they completed basically a 30-minute ultrasound course, looked at them before and 1 month after, and they found that participants' performance for identifying structures improved, as well as the average time to completion decreased. And this applies basically to orthopedists of all training levels. This next study found that after a brief teaching workshop, their proficiency in detecting rotator cuff tears specifically was comparable to an experienced radiologist or an MR orthogram. And as surgeons, we already have a profound knowledge of this patient's anatomy. So that, combined with the knowledge of the patient's clinical symptoms, actually makes us ideal candidates for using ultrasound. So this study, interpretation by a surgeon of ultrasound images after a clinical exam with the patient, was actually more accurate than a blind interpretation by a radiologist. So in terms of coding and billing, just for completion's sake, there are separate CPT codes for ultrasound. These are the associated RVUs with it. If you are doing it for an injection, again, it is going to be more, but that is not me advocating for using ultrasound for every injection. While it can be useful, and there are studies, for example, Dacre-Vein sinusonovitis is shown to have better clinical outcomes, but for using it for kind of all major large joints, while it does improve accuracy, the literature shows that it doesn't help clinical function, particularly in terms of pain and function. And this last is just like a level 3 office visit, how many RVUs you get for that for resident background information. In terms of future advancements in ultrasound, one of the primary limitations of 2D ultrasound is the difficulty interpreting the image. However, 3D ultrasound has the ability to overcome these shortcomings. Most of the work in this is actually done in the scoliosis world with the ScoliScan, which is basically a 3D ultrasound assessment. But there are specific limitations, particularly interference, the bone boundary thickness, your field of view, and we're also lacking validation studies. But future advancements with this technology will make the integration of this modality easier. This is just an example of kind of the bridging callus that you can see over time with 3D ultrasound. Also on the horizon, Dr. Rice will be doing a study looking at soft tissue infections with ultrasound. So be on the lookout for this, as well as possibly a resident training course for us to become more familiar with using it. As we think back to our cases, this former college athlete on the court, luckily one of his co-residents was there with an ultrasound probe in their bags. They're able to stick it to the ankle, and here you can see calcaneus gastroc, Achilles tendon rupture. So this was able to kind of facilitate this patient's care where they didn't have to wait around for an MRI. They're able to get in and get immediately seen. This patient with the pacemaker was actually unable to have an MRI. So here you can see full thickness supraspinatus tear on both the long and short axes of ultrasound. And finally, our baseball player who had ended up having an UCL tear. And here's just a dynamic video showing gapping or opening up of the ulnohumeral joint with a dynamic ultrasound exam. So in terms of why you would prefer ultrasound, affordability, it's going to be much cheaper than MRI. In terms of accessibility, it's portable. You could do it in clinic. It's a one-stop shop. Your patients don't have to be sent out for an MRI and come back. I think it's best for answering specific clinical questions that you have. Accessibility of MRI. I know I still have patients at CMC Maine waiting around for an MRI from back when I was in trauma last year. In terms of accuracy, I've shown the applications where it can be equivalent to MRI. The ability to perform a dynamic exam is unique to ultrasound. Patient satisfaction, they actually prefer it. And it's relying on the physician. So you're not relying on an outside person, a radiologist or a technician. So we've seen the growth and evolution of technology, specifically the global market for ultrasound, which is expected to increase from 6 billion in 2018 to around 8 billion by 2023. There's a growing expansion for the use of ultrasound, and I've tried to demonstrate some of its applications in orthopedics, only meant as an introduction to its utility in our practice. So I think it's important we just keep an open mind as technology continues to evolve, because we don't want to end up like this guy or the founder of BlackBerry, who basically stubbornly clung to the idea that people would not want to use their smartphone from anything other than email or phone calls or texting. So thank you so much for all who have helped me prepare.
That's great, Risa. Enjoyed that review. If you want to stop sharing your screen there, and we can look around for questions. I guess the first question that I might pose to you is that clearly it's become more commonly used, but the big transition for something that's sort of treated as a novelty is that transition to when does it become sort of the standard of care or the gold standard for certain things. So in your review, you had a pretty comprehensive review of the different uses of it. What are going to be, in your mind, the first, first couple of things where it is truly the gold standard, and in common day orthopedic practice, if you're not using it, you're antiquated?
So in terms of the gold standard, I'm not sure, I think I can think of several applications where I think if you're answering a specific clinical question, it can be useful. I think right now, particularly with ultrasound and getting facile with it, it's really more seen as an adjunct. So I think in orthopedics, it can help us determine maybe which patients you do need an MRI instead of pulling the trigger and getting an MRI on everyone. Right now, I think it has very useful advancements with particularly diagnosing carpal tunnel in the office, and not sending patients out for nerve conduction studies. But I think it's not going to be an end-all be-all for a gold standard, because you have to evaluate the patient. So in that situation, if your patient's having maybe neck symptoms, you might want to do the nerve conduction study, because then you're going to see more, is this peripheral related or not. So right now, I don't foresee it being the gold standard for anything. I think it's more seen as an adjunct to helping a clinical diagnosis. I think for some soft tissue infections, it can definitely help to avoid basically getting advanced imaging such as CT scan. If you can put an ultrasound probe to it and then know that's your diagnosis, then your patient doesn't have to go through the CT scan and for all that. But right now, I think it's still mainly for adjunct and helping answer a specific clinical question that you might have.
See, I think it's a good, points you raised there in your answer. But the question is, like for carpal tunnel, the benefit of ultrasound is that the surgeons can actually bill for it and get real-time information. So it's sort of a dual-fold benefit. But for payers, when are they going to recognize or reward people for not getting those nerve conduction study tests, not getting the MRI? Is there a time, is there a classic presentation where somebody has just, a perfect clinical exam for carpal tunnel, has a correlating ultrasound, and you don't get anything else? And, that's going to be that transition point that we see with this technology and its integration into our practice. Anybody have any other comments or questions?
Hey, Risa and Josh, it's Natick. I can give you a little bit of a different perspective on it. In my fellowship at WashU in St. Louis, they're probably considered the world's leader in using shoulder ultrasound as a primary diagnostic tool for rotator cuff tears. And I was excited about that when I went there for fellowship. I was excited to learn about it and use it and have it as part of my practice. But when I got there, I realized that the surgeons don't do the ultrasounds at all. It was all done by the radiologists and radiology technicians that have been doing them for years. And I learned very quickly that it's actually has a really steep learning curve, and you can't really learn it in a half day. It's something that takes a little bit more practice than that, and the quality of the images are pretty user dependent. So when you look at the literature, you got to be careful about how they're doing it in their system. A lot of times it's done by radiologists, and they have a factory, and they have experienced radiologists that are really good at it. And in other places, it's the orthopedic surgeon who's just kind of learning it on the fly. And I think that's a little dangerous and can be misleading about how you're getting the ultrasounds and how they're trained. There's some people around Charlotte that are learning how to do it. I think that's fine, but I don't think the message should be that this is something you can learn really quickly or through an online course. I did it myself, and I learned it in the last few years, or a few months of my fellowship, and it's actually pretty challenging to get good quality images. So I think if you are going to start to use it in your practice, which I fully endorse, a good way to do it is to do ultrasounds, but then not bill for them, and then also get an MRI or the other gold standard diagnostic tool for a while until you feel really comfortable that you're able to diagnose things well, because this could be the difference of somebody having surgery or not if you're calling a full thickness cuff tear on your ultrasound. But it just, I think there's a way of doing it safely, and if you're going to commit to it, you have to commit to it. Your practice has to commit to it, because the ultrasound machines aren't cheap. They take you a while too. So if you're going to do it as the orthopedic surgeon, you just have to have the resources to do it. It's going to take you about 30 minutes in the office once you first start to do them, and you got to get a good machine. And then for a while, you should probably back it up with MRIs until you feel really comfortable with your ability to diagnose things. So I thought it was a great review, and I do think there's huge potential for us to use this in orthopedics moving forward.
Reese, I don't know if any of the primary care guys are on the call. They've actually had more experience than the rest of us have with this. They use it every day in their clinic. But one of the other end of the spectrum, Josh, from standard of care, which is over here, is sort of the cutting edge. And they now have these butterfly ultrasounds they can take on the sideline. And if somebody gets an injury on the sideline, they can actually evaluate it right now. So I'd almost be interested in hearing a little bit about that. Reese, I don't know if you came up with anything. You can phone a friend. I see Eric Warren there. If you haven't had any experience with it or read about it.
Yeah, so I briefly talked to Dr. Price about
sorry,
it.
go ahead.
Sorry, Dr. Warren, you could probably elaborate more. Basically what Dr. Price was telling me was the ability, I think the quality has improved over time, and he does have this portable ultrasound that they can take to the sideline, but I'll let you elaborate more, Dr. Warren.
Yeah, sorry to interrupt. First, I'll say great presentation. Secondly, fully endorse getting the MRI and looking with the ultrasound, and even doing that afterwards. If you had the MRI result, then putting the ultrasound on to find the findings that we're seeing on the MRI. But in terms of portable ultrasound on the sidelines, it's a great satisfier both professionally and for the athlete to be able to look real time, make return to play decisions. Is the weakness based off of pain, or is it based off a structural defect? Those are great things to be able to determine. The one caveat I'll give is that if you bust out a portable ultrasound on the sideline, be prepared for most everyone to want something looked at. So I've even had coaches who wanted something that's hurt looked at, since it's right there waiting for them. So you better be ready to use it if you show it there.
Great. Let's see, Eric Sechrist, I see you've had your hand up here. Maybe one last question before we move on to Dr. Haynes.
Yeah, one question for, I don't know if this would be for Reese or perhaps one of the primary care guys, but I've thought about asking for an ultrasound machine in negotiations with jobs. And one of the obvious questions there is, how many injections would you have to do before you would cover the cost of the machine so that you hit a break-even point? And I know this came up a lot with Ortho Carolina when Dr. Weeks was starting here. Any input from a dollars and cents perspective from anybody who uses this thing more often than us?
So Eric, I think that's a reasonable question. We'll see. Or Dr. Warren, maybe you can answer that for us, or try.
Yeah, so a lot of these machines you can do on a per month lease, or in terms of capital, how you're depreciating and paying that back. So it only takes a couple ultrasound injections usually to make that $250 to $350 monthly coverage. So it's really not a whole lot that you have to be able to do to cover the cost.
And I think the other thing, Eric, you'll see, not just with this, but anything, and there's a good lesson for all residents going into practice, is that it's also a differentiator. So it may not be a hard dollars and cents, even exchange, but if you can bring something different or unique, and it's something that's marketable, that, gives you a certain, cachet in your community, there are some side benefits to that. So, whenever you're asking for something, be thoughtful about how you can sort of sell it, if you will, to your practice, to your hospital, whatever it may be, in terms of what you could bring that's a little bit different, and, what the future is, and, leaning back on this talk and understanding what other potential uses in the future for your practice would be, might help you sell that. So I think it's a good example of how you can look for something that you want in your practice, maybe, and figure out a way to make it more broadly applicable or marketable. So, well, Risa, thank you very much for a great first talk this morning. I think everybody enjoyed that, and we will let Dr. Haynes come on over, and we're going to hear about patella fractures for the second half of the talk this morning.
All right, thanks, Dr. Pat. Go ahead and get started. I'm going to talk a little bit today, just review patella fractures. I have no disclosures to report, and we'll go ahead and start with some cases. The first one is a 57-year-old female who slipped at the airport. She had immediate onset pain and inability to extend her left knee. She was brought to the CMC emergency department and was noted to have effusion and ecchymosis. And again, she couldn't extend her knee. Case 2 is a little more complex. It's a 22-year-old male who's a professional hockey player. He's presenting for a second opinion. He had ACL reconstruction 5 months ago by another surgeon with a bone patellar tendon bone autograft, and has been having some anterior knee pain for the past 3 months, as well as some weakness with extension. When he went to go see his surgeon, he was noted to have a slightly lax test, on a Lockman test, compared to post-op. So the MRI was repeated, and here you can see that 2 cuts of the ACL, which appears slightly bulbous, but overall looks like the graft is intact. This was also noted on his MRI, the stellate fracture of the patella, which was, minimally displaced. When he came to our clinic, these were the x-rays we obtained. He did not have any additional injuries, after the initial rupturing of his ACL. Just some basics on patella fractures and the patella in general. It's the largest sesamoid bone in the body, articulates with the medial and lateral facets of the distal femur, making it a directorial plane joint. The dorsal surface is subcutaneous, which makes it easy for surgical exposure, but presents challenges in avoiding symptomatic hardware. I think an interesting point about the patella is that only the superior 75% of the patella's height is composed of articular cartilage. And that cartilage is very thick, some of the thickest in the body, at up to 1 centimeter thick. Biomechanically, it functions to increase the distance of applied force from the center of knee rotation. This has been shown to increase the moment arm of the quadriceps by up to 3%. It undergoes loading primarily during extension, and undergoes tension, compression, and 3-point bending while the knee is being flexed. So now we'll kind of talk about patella fractures, which are all come in many different shapes and sizes. There are multiple classifications. The first one I'm sure we're all familiar with is the AO classification, which you can see here. It classifies them as extra-articular, partial articular, and complete articular fractures. Has not been shown to be very helpful and is not commonly used. More commonly, what we do use is this fracture pattern classification, which really is just a descriptive classification, whether the fracture line is horizontal versus vertical, displaced, non-displaced, inferior pole or superior pole fracture, or an osteochondral lesion. There are two main mechanisms for patella fractures, and I think this is important. The first one is failure under tension. This usually happens when the quadriceps is eccentrically loaded and results in a transverse fracture or inferior pole avulsion. Commonly, the extensor mechanism is disrupted, as well as some of the knee retinaculum. And then the second common mechanism we see is from a direct blow to the anterior knee. This is most commonly seen in patients that are involved in motor vehicle collisions where their knee hits the dashboard and usually results in a multifragmentary or stellate pattern. And interestingly, greater than 50% of these fractures from this mechanism are non-displaced or have an intact extensor mechanism. On physical exam, you see a hemarthrosis, palpable defect or fracture gap and inability to extend the knee. And then keep an eye out for open fractures, just as they're so close to the skin and subcutaneous tissue. If there's any question, you can saline load test the knee to be sure. Treatment of these fractures, so non-operative treatment is usually reserved for minimally displaced fractures with an intact extensor mechanism, or displaced fractures in those who are too medically fragile to undergo surgery. Usually this consists of immobilization for 4 to 6 weeks before starting range of motion exercises, and patients can be placed in a long leg cast or a knee immobilizer or a hinged knee brace, depending on how you think their compliance will be. Operative options, there are many, and this is not an all-inclusive list. I'm going to try and highlight some of the most common methods we use, as well as some of the advancements that have been made over the past several decades. Indications for surgery. Really, I think the biggest takeaway from this is if the patient has a disrupted extensor mechanism, that is probably the most absolute indication. As far as displacement of greater than 2 to 4 millimeters or step off of greater than 2 to 3 millimeters, I cited a paper below that was a review article, and this is what they recommended. When I went back and looked at their primary source, there was no absolute mention of these numbers. Rather, it just said that it's okay to treat, non-operative patella fractures non-operatively if displacement is less than 1 millimeter. So I think there's still work to do. We don't really know. Obviously, if there's displacement, it pushes you towards operating. And then anybody with an intra-articular loose body, as well as open fractures, certainly need to think about fixing those as well. The goals of surgery are the same for basically any fracture we treat. You want an anatomic reduction at the articular surface and interfragmentary compression to allow for primary bone healing when possible. Some other things to think about are associated injuries, as these are common in polytrauma patients' age and functional status or comorbidities, their bone quality and how much purchase you can get in your fixation, the patient's weight, as they will be weight bearing on this eventually, and then their compliance with your postoperative recommendations. So the tension band technique was the gold standard for a long time. It still remains the most common technique. It is best for transverse fractures, and it's thought to lead to dynamic compression at the articular surface with the knee inflection, although recent publications may have called this into question. I think, this is a extensive topic that could be debated at a later date and is outside the scope of my talk today. This was traditionally used with 2 K-wires, perpendicular to the fracture site, and then an 18-gauge stainless steel wire and a figure of 8 pattern to provide compression. This retrospective study done in 1985 looked at 100 patients, although some were not included in the final analysis for random reasons. Subjectively, they had 72% excellent or good outcomes after undergoing a tension banding construct. And objectively, when they looked at their, quadriceps wasting and strength and range of motion, they felt that about 80% of them had excellent or good outcomes. But there were many complications with the tension band back then. 32% were noted to have inadequate reduction with articular step off. 37% had a broken wire loop. And then 15% had pain requiring hardware removal. And there was noted to be a low infection rate. Similar results were found in this meta-analysis out of HSS in 2012 that looked at rates of reoperation, infection, and non-union. Notably, infection and non-union are low, but the reoperation rate in all these studies they analyzed was 33.6%, which seems extremely high. A biomechanical study done looking for a solution to this. People have looked at using a polyester suture instead of the tension banding technique in order to prevent prominent hardware. This study was done on transverse fractures in cadavers created using an osteotome, and they created a tension band using suture. They found that the tensile strength of the braided polyester was lower, as seen on the graph on the right, but did not fail after 2,000 cycles. And they felt that it was a acceptable alternative to tension banding with K-wires and wires, and thought fewer hardware issues. A follow-up study of that, people started using cannulated screws across the fracture site for transverse fractures, and then fixing it with fiber wire going through the cannulated screws in a figure-of-8 fashion. This study is another study done on cadavers in Florida in 2015. They performed the construct I mentioned previously, and it showed statistically no difference in fracture site displacement or maximum load to failure between the steel and fiber wire with cannulated screw constructs. Because fiber wire was not significantly weaker, this was also recommended over traditional tension banding. And then just to add to that, these authors did a retrospective study looking at actual patients where they did cannulated screws across a transverse fracture site and then fixed it with fiber wire and a figure-of-8 pattern, as well as a running locking cerclage around the patella. And overall, they had good outcomes. 49 went on to radiographic union at an average of 3 months. Only 4 patients, which was 8%, had to have hardware removals or additional surgeries, and 3 of those were due to prominent screws. And then just notably, the range of motion, almost 0 degrees of extension and an average of around 120 degrees of flexion in their patients at 2-year follow-up. Plates are another option and are gaining popularity throughout the orthopedic community. They're most commonly used for multifragmentary fractures, although they're gaining popularity for more simple fractures as well, as they become more low profile and somewhat cheaper. Sorry about that. These are located dorsally, directly subcutaneously, and the fracture is reduced and either held in place with screws or clamps until the plate can be applied. And then you just have to think about cost when using this fixation method, as it is more expensive. This biomechanical study performed in 2012 tested the durability of traditional anterior tension wire versus cannulated screws with tension wire versus 2.7 millimeter fixed angle plates, which you can see on the right. They cyclically loaded the knee and ran it for 100 cycles, and what you can see here is that the fixed angle plate performed the best compared to screws and tension wire versus tension wire and K-wires. Likewise, for a clinical perspective, this study was done out of Beaumont Hospital in 2017. They looked at 12 patients with isolated displaced patella fractures, 9 of which were multifragmentary. They had a mean follow-up of 19 months, looking at their radiographs, functional outcomes, and physical exam. All of the patients went on to have union by 12 months and had satisfactory functional outcomes per the authors. And there were no reoperations in cases of infection, non-union, or symptomatic hardware among their study group. Going even lower profile, surgeons have started using this contourable craniofacial mesh plate osteosynthesis for patella fractures. This is actually a case series out of Ohio State in 2019, looking at only 4 patients, 3 of which had comminuted fractures. They used independent screws in this mesh plate, which you can see here, that is extremely low profile. They had 100% union rate. They had no symptomatic hardware. The only downside they felt in this study was the increased cost at $660 versus $345 for more standard mesh plates. An option in these cases is always patelectomy. Doing a total patelectomy is rarely indicated in cases of tumor, infection, or revision surgery is when it's most commonly used. And it leads to about a 50% reduction in quad strength. So try to avoid that at all possible, and it's become less popular over the past several decades. And then partial patelectomy, there certainly is a case for this to be used. It's reserved for extremely comminuted fractures of the inferior pole, especially when the patients have poor bone quality and the patellar tendon can be advanced. This sometimes leads to patella baja and then alteration of the extensor forces on the knee. A couple studies, or one study showed up to 55% of patients developing osteoarthritis in their patellofemoral compartment at 2-year follow-up. And then it's recommended to leave at least 60% of the patella when doing a patelectomy. Speaking of inferior pole fractures, there are other options for this as well, including a basket plate, wire fixation, suture fixation, or the patelectomy. This 2016 study compared fixation of inferior pole fractures with suture anchors, as shown on the right, or partial patelectomy. They retrospectively looked at 60 patients, 27 of which were treated with the suture anchors and 33 of which had the partial patelectomy. Both groups had similar numbers of complications, including infections and reoperations. However, the suture anchor also had additional non-union implant failures that the patelectomy hadn't seen. The authors did recommend, though, that this was an acceptable fixation technique, as there was a shorter overall operative time of 68.5 minutes versus 79.1 minutes. And then they also noted that, it's a good alternative to basket plates, which have up to a 50% need for hardware removal. And these are some more interesting techniques I found in the literature, none of which are used commonly today per se. This one has to do with Nitinol Staples. The AO Institute looked at this using 2 Nitinol staples for transverse patella fractures and cadavers. They found that it performed better than traditional tension band wiring construct and thought that it may have potential implications for future fixation techniques. As they noted here, it has a promising potential to treat transverse patella fractures. Nitinol, as far as clinical applications go, this study out of China used a combo of cannulated screws and nitinol plates to fix patellar fractures and had excellent or good outcomes in 92.6% of patients. And then a 2006 study out of Turkey even used an X-fix circular ringed X-fix in order to preserve soft tissues in patella fractures, although this has not caught on in clinical practice. Post-op protocol, there's really no clear consensus for these patients. Each rehab program should be modified to fit each individual case, given the patient's age, bone quality, fixation type, and fixation stability. They're traditionally kept in a locked-in extension for 4 to 6 weeks, and our weight bearing is tolerated. After that time, they then go on to progressive range of motion exercises and are performing active extension strengthening at 12 weeks. But more recently, to avoid knee stiffness, patients have providers have begun advancing range of motion exercises earlier. This study looked at patients treated with low profile mesh plates for comminuted patella fractures. 9 patients were casted for 2 weeks and then placed in a hinged knee brace until union. Range of motion was started at 2 weeks post-op under PT supervision, and all these patients had good or excellent results. Going back to our cases, case 1, this 57-year-old female, you can see here, she has that transverse fracture best seen on the lateral, but she also has these 2 small intra-articular fragments noted here. She was treated with this low profile mesh plate that was contoured to fit her anatomy. Several independent screws were placed from inferior to superior to create compression at the fracture sites. And then the locking plate was applied. She was kept in a knee immobilizer until 2 weeks post-op, at which point she could range from 0 to 30 degrees and then advance 10 degrees a week after that. She was last seen in December of 2021 virtually, was doing well. She had some anterior knee pain and she had full extension by then, but flexion was limited to 80 degrees. She was going to continue formal physical therapy to get her range of motion back, but overall was doing very well. Case 2 was our 22-year-old male hockey pro player who presented for a second opinion after it was recommended he undergo ACL revision. He was referred to our trauma surgeon at Atrium, who treated with him with an tension band technique using cannulated screws and 18-gauge wires in a figure-of-8 fashion. Afterwards, arthroscopy was performed, which demonstrated an intact ACL graft and no other significant injuries. Here are his fluoro shots from the case. He was made protective weight bearing until his quad tone returned. He began PT at 2 weeks to work on range of motion and some gentle strengthening, and his range of motion was advanced at 6 weeks. He was last seen 3.5 months after surgery. He then moved to train for the off season. His range of motion was 0 to 90 degrees, and he has never come back for any hardware issues or any other problems. He is still playing minor league hockey to this day and has 4 goals on the season thus far, so is doing great. And then this study, looking at the incidence of patella fractures and their outcomes after ACL reconstruction, was published in Arthroscopy in 2002. They looked at these 618 patients and found 8 of them with fractures, which is consistent with the literature showing about a 0.23% to 2.3% incidence after ACL reconstruction with bone, patellar bone, tendon autograft. And then also consistent with the literature, these patients either had stellate or transverse fractures after this mechanism. 3 occurred from direct trauma and 5 occurred from indirect trauma. And at a mean of 57 days post-op, 5 of these were displaced and went on to fixation. Overall, they had a 75% patients had good or excellent Lysholm scores at follow-up. So in conclusion, most of these displaced fractures benefit from fixation, especially when the extensor mechanism is disrupted. To present day, there still is a high rate of reoperation for hardware removal. I think future studies need to be done to determine whether, plates really do help decrease this, or the suture with cannulated screws can help. We still don't have a great answer, although it seems we're moving in the right directions. And then, the question of whether or not these patients, their weight bearing can be advanced earlier, I think, we have starting to have some evidence showing that this is a good idea and can be done safely without worrying about non-union of these patients. The takeaway here is that the management is really patient and surgeon dependent in most of these instances. I want to give a special thanks to those who helped me with this presentation. Here are my references, and I'll open it up to any questions.
Excellent. Thanks, Bryce. Appreciate that. My favorite thing to do with a patella fracture when it comes in is to refer it to someone else. I find that to be the most satisfactory way to treat extensor mechanism injuries. Certainly you bring up some great points in terms of hardware prominence, and that's always my concern with all of these. It's like fixing olecranon fractures. I don't think these are all that different in terms of just baseline hardware issues. Be open to anybody's comments, folks who actually fix a good number of these.
I'll make a quick comment. Bryce, interesting topic, good choice. What we've learned over the course of the past few years is that outcomes for patella fractures are not as good as we thought. And this really highlights it well. It's a good incorporation of literature. Not a good question, but I can tell you that if I could go back in time and find the person that told the world that fractures heal in 6 weeks, I would eliminate that person, because of patella fractures, the patients are miserable for a really long time. And they actually do require a fair amount of rehab and recovery. Hopefully some of the things that we're pushing forward with earlier rehabilitation for a variety of different injuries will help, but we definitely need help in this zone with recovery, not necessarily just healing.
Bryce, great presentation. And one thing that I would appeal to the group for is, obviously in some of these, Humpty Dumpty cases where they're in a million pieces, you don't have much choice in the post-op rehab, you got to go slow. But I've seen so many of these people get stiff that I really think one of the imperatives is to develop a construct that allows you to move them early. And the nice thing about a tension band construct is just like the olecranon, you can actually move it, and the effect of the quad on a tension band is actually to compress at the fracture. So that I think is probably one of the better constructs, whether you're using the suture, which we use more commonly now. The wire always breaks, the wire is always a mess. So I think we've gotten away from wire, but some sort of a dorsal structure that allows you to compression at the fracture site with quad activation, then you can move them a little earlier. Because we end up scoping an awful lot of these for arthrofibrosis that don't get moving. So obviously the tension between the non-union and the arthrofibrosis, but in some ways, I think you can accomplish both if you just watch them carefully.
Bryce and Steve Sims, that was a great review and a great talk. I agree. I think when you see any fracture that has this many treatment options, and you keep seeing more and more new things come along, it usually means because we haven't solved the problem yet, and it still is a very difficult problem. It's a very subcutaneous bone. It sees a lot of stress and a lot of force across it, and long-term patellofemoral problems are certainly a problem that persists. So we certainly have not solved this problem yet. But I agree with Dr. Moorman that I think for most people the concern is when they're bending their knee and weight bearing, where they see a lot of force across the knee and pulling it apart. So I think a lot of people will allow them to walk on it, maybe have them an extension when they walk, but then take the braces off, or have some drop lock hinges or something that allow them to move it very early, because just the range of motion should not be enough to pull this apart or to cause a problem. But walking on it or rising from a squatted position or squatting with the forces across can be problematic. I've also had the very humbling experience of having several of these patients that had an arthroscopy after you do your fixation, and you think you've got it perfect, and you look at the articular surface underneath and it didn't look as perfect as you thought it was. So I've had several times we've revised it at the same operation while they had the arthroscope in. So I've often wondered if arthroscopic assisted for some of these simple fractures wouldn't be the way to go to really get them lined up well. But interesting review, and thanks for that topic.
For the residents, I think that Dr. Shu's comment was very appropriate and 100% agree with. One of the things that we learned from just patient satisfaction studies is that appropriate expectations will guide patient satisfaction, quite a bit. So I think it is very reasonable when you encounter one of these to just give people a heads up that this is a year-long recovery to get back to full function, and probably 2 years before you hit MMI. And MMI might not be their premorbid condition. You can give an example of a football player with an extensive mechanism injury. They're out for a year. So I think that that maybe doing a good job of giving patients appropriate expectations is really important. So certainly agree with Dr. Shu's comments here. But thanks to everybody this morning for participating, and 2 great talks. We will look forward to seeing everybody virtually again, hopefully just one more time next week. I believe we have M&M, unless I missed a calendar switch, but we'll see everybody next week for conference. Have a good day.